Our next speaker is Professor Abdulrahman Jebreen. He's the Professor of Medicine, Gastroenterology, Hepatology, King Khalid University Hospital. He's the former President of Saudi Gastro Association. Professor Jebreen will talk about the big bile duct stone, what to do.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everybody. It's really my pleasure to give this talk, and I have to thank the organizing committee to give me this opportunity. My most of talk is actually videos, and unfortunately this morning I recognize that I cannot use my laptop. So I will do my best, hopefully, to give this talk, and hopefully some of these videos that I take into my USB will work. So to start with, how to deal with the difficult stones. We always face the difficulty of defining what's difficult stone. A difficult stone for someone might not be for another one. So there will always be some variabilities in defining, even in the literature. We can go to the literature and find some of efficacy of that procedure or the other one, and you go through the methodology, you will find some actually variability in the definition of a stone. What are the basic maneuvers? What can you use, like in terms of other options beyond the conventional method? And is there anything, any new procedure that might expand the pool of CBD stone and use it for other options that we don't usually use and we usually send for surgery? A CBD stone in combination with Dormia basket or balloon catheters, more than 80 to 90% of CBD stones can be treated by endoscopic sphincterotomy and stone extraction with balloon catheters or with a basket. With the addition of mechanical lithotripsy, the success rate for endoscopic stone extraction might reach up to 95%. As you can see, this is a picture of a huge stone. You could, the moment you can capture the stone with a lithotripter, you can most of the time extract this stone and you can relieve it. Although conventional techniques for stone removal are highly effective, they may fail in up to 5 to 10% of patients with difficult CBD stones. And it always comes to what's a difficult stone. Many definitions. Some people will say it's really based on the size. So for example, a size more than 15, this is a difficult stone. And as a therapeutic endoscopist, you know, sometimes you can find the largest stones up to 20 millimeter, but can be removed easily. Or could that be an impacted stone? Or a patient with previous surgery, for example. Any patient, for example, with a stone with a distal stricture, that could be difficult. Or a patient with intrahepatic stones, where you cannot go to that intrahepatic duct to do this kind of maneuvers. A difficult stone, in my opinion, can be defined as a stone that could not be removed from a bile duct despite doing endoscopic sphincterotomy, using a basket and or balloon extractor, mechanical lithotripter, and another very important, in my opinion, which is the balloon dilatation of the papilla of Vater. Kim et al. Prospective evaluated factors contributing to technical difficulties in removing CBD stone found that elderly, previous gastrojejunostomy, large stone size, impaction of stones, short length of the distal CBD, or the acute angulation might actually add to the difficulty of the stones. Many times we'll be referred, we'll have a referral for a difficult stone. And when you go to this, for example, for spyglass, for example, or shockwave filtered ESWL, or any other modalities, and before you go to do that, you find there are still some actually procedure not done, whether this is mechanical lithotripsy or, more important in my opinion, endoscopic papillary balloon dilatation. And there are actually numerous studies that find this maneuver, it could actually reduce the need for mechanical lithotripsy, shortens procedure and fluoroscopy time, lower probably cost of hospitalization. And you can actually remove as big as a stone as this stone. So before you go ahead and go use this difficult, fancy procedure, try to do the basics. And I think that's a very important message. Previously, we used to use in our unit the extracorporeal shockwave lithotripsy, the ESWL. It can do the job, not probably the best. It's, you have to do the RCP, of course, then you use an nasopapillary, then send the patient to the extracorporeal shockwave lithotripsy unit, usually in our colleague in the urology department. You have most of the time, you have to be around during that session. You need most of the time also general anesthesia. And you have to go back for ERCP. And unfortunately also, it's not free of complication, including cholangitis, hemophilia, hematuria. One of the things in extracorporeal, the problem is not only the success rate, but how many times you need ERCP. And most of the time you need probably from 2 to 3 sessions using this modality of treatment. Then we come to the era of a cholangioscopy guided therapy, whether using the EHL, the electrohydraulic lithotripsy, or the laser lithotripsy, which are being performed under direct visual control using a cholangioscope. Traditionally, a long time ago, we used to use the perioral cholangioscopy with the mother-daughter system, which involves a complex equipment, requires coordination between 2 experts. It's a very difficult, and even the visualization, it's not really that great. So most of the people really moved from this modality, although it's being used and it's been successful, almost success rate up to 90, 100%, but because of the fragility, poor optical resolution, it's hamper really their utility big time. What about the new method? In probably 2006, the spyglass was introduced to the market. We were among the group which been excited by this new development. It's unfortunately not the best even. The best things in this, it's single moderator. You don't need any other people. So you are endoscopists, you can do it. The problem with this, the resolution is not really that great. It's hard when you try to introduce it, and always having difficulty sometimes with the fibers, because with the fibers it tends to be broken and you have to repeat it. And when you want to introduce, for example, a laser or EHL probe, then you might have actually difficulty in going through. However, we were excited in doing this. We have to learn it. It's a very difficult, I have to tell you. I have to try many times before I can be successful on that. So we started our actually procedure in probably late 2010. We carry on. We published our actually first experience in the Saudi Journal of Gastroenterology among 13 patients. In 1 year. Bile duct clearance was achieved in 100%. All of our patients, we were being able to, some of them actually has to go through 3-4 ERCP before we enroll them in the spyglass procedure. we required, which is very good compared to the shockwave lithotripsy, 76% required only 1 ERCP, and it's during that procedure. So you do the cholangioscope, you do the EHL, you fragment these stones, and then you remove them in the same session. 7.7 required 2 procedures, and 15 points required 3 procedures, with, as I mentioned previously, 100% success rate. Adverse effects cholangitis occurred in 1 patient. In the same study, which we were published, we compare this to a historical cohort with, our historical cohort with shockwave lithotripsy. 64% of shockwave lithotripsy complete CBD stone clearance in our data, which is not really far away from being published, which is about 75%, based on, as I mentioned, the definition also of your stone, a difficult stone. If using a very difficult, strict definition, then obviously the efficacy will probably be lower. Using a single operator cholangioscopy system on 75 patients with difficult CBD stones, again Farrell et al. Had shown a 100% success rate with no complication, which is consistent with our data. Adamak compared the clearance rates of shockwave lithotripsy to HL in 35 patients with difficult CBD stone. ESW had a success rate of 72% versus 76 rates among the EHL group. Their efficacy result was below than reported in most recent study, I have to say, which is almost going to most of the 90 to 100% success rate. Laser lithotripsy, we don't use it in our unit. However, it's been used and it's probably very good. The only thing probably might hinder that is the cost. It's very highly costly. Some people probably saying it's probably safer, although I believe when you use it under a very good direct visualization, especially with the new digital DS spyglass, you can use it very clearly. I think that the effect in terms of burning the wall will probably very, very minimal. What about if you cannot do anything? Then yes, biliary stenting is an option. It could be an option for an elderly. They cannot go through a very really long procedure, especially with the new, with the old spy glasses. It might take actually up to 1 hour. You need sometimes general anesthesia. So sometimes you just put a biliary stent and that's all. This is a case, I hope the videos will work, but this is a 21-year-old female presented with abdominal pain and jaundice, found to have large CBD stone on ultrasound abdomen. 3 RCP were failed, stented, waiting for to clear her CBD before lab chole. What are the options? You could say we can go again and find it, but these actually 3 been done by an expert. 2 of them actually been done in UK. She was actually a student in UK, and the first 2 been done there. The 3rd done in another, also a very good center. So would you go through again doing, for example, balloon dilatation, mechanical lithotripsy? Indeed, in these cases, I don't do it anymore. I use the spyglass, especially with the new digital AS. I go ahead and directly I can see whatever I want to see, and I direct the EHL there. And most of the time, you can actually break it in a 1 session, and that's what actually happened in this patient. This is, you can see the stone there. It's impacted, and that sometimes you didn't see sometimes a bigger stone, but sometimes it's impacted. They try to get the wire over this one, but they cannot. And my suggestion, don't waste your time really on this. Try again, because it might take you 15-20 minutes with this procedure. At the end, you will use the other method. This is actually the new DS spyglass. This is what actually we've seen. You can see it very clearly. You can see the probe, which is I don't know how can I use it, but that's the probe indeed here, and you can direct it exactly at the stone. You can fragment it, and depend really on how many shots, what's your power. I usually go with a lower shot like 3, then I can go up to 10 per minute, then I go as higher as 100 sometimes in the power, and usually most of the time I have to say 100 so far 100% success rate. We use the new digital one up to 10 times now. Over the last 2 months, actually, it's just been introduced, and we use it up to 10 times, and it's always successful, and it's very good. And comparing to the old one, we only use it for about the total procedure time, probably 20-30 minutes maximum, and it's very good actually. This is a video, but I doubt it will work. It's not actually videos. It turned out to be now pictures, so I don't think it will work. Maybe it will work. Great. So this is actually the first case. You can see this is the probe. This is a large hard stone. That's the first case actually. We're using now the lithotripsy. You can see the vision is very actually clear. You can see the cracks now.
Two minutes, Dr. Abdulrahman.
Sure. It's almost maybe. Yeah, you can see the catheter inside now the stone. It's being cracked already. So you need another probably 2-3 minutes. Then you can use your balloon or catheter or any other. Since I have 2 minutes only, I'll try to use another one, hopefully. Yeah, it's been cracked already, so that's... You have to finish your job. Even if it's a cracked, I have to take more time to make sure that I don't go back again, because to take out the spy glass and go with a balloon, then back to the spy glass, it's actually a lengthy procedure. So I try to finish my job in one time. Okay. I think this is the one. I need your help. Okay, so this is the final one. So we use the balloon, we use this, and this is the final cholangiogram finalized and the patient being discharged. And we got so excited. We had another case, a 50-year-old Filipino nurse, hugely dilated biliary system, including intrahepatic duct stones, failed multiple, 5 ERCP failed. This is what's here, even with just a little cholangiogram, hugely dilated CBD intrahepatic duct. In this patient, we have actually video, but I don't think I have full time to view it. But we went through the intrahepatic duct, and we used the EHL, and we finalized this patient. However, in this specific patient, we have to, this is the cholangioscope. You can see that's exactly the the spyglass, and we use the EHL inside the intrahepatic duct. It's been fragmented. However, when you have a very difficult, actually big stones, hugely dilated, then always it's safer to put a stent, because risk of cholangitis is higher in this patient. I will have to go to, since we used it, we actually been involved in what we call the Spyglass Asian Middle East Registry. We've been among up to, I think, 54 sites among Asia, Middle East. We recruited 16 patients so far. We start recruiting with the new digital or DS Spyglass. This actually data being presented in the last Asian Pacific meeting. and we are proud to be one of those sites. The question is, can we extend the pool? Especially we can improve actually the visualization. With the spyglass, actually, you can go to any duct that you want. In addition, you can actually go to the cystic duct. So in case, for example, of Meritzi syndrome, you probably can go through the cystic duct. You can actually crash it. Not only this, even I'm thinking of patients of, for example, fragile patient with cholecystitis. Can you go through this with directing your actually stent through the spyglass, and you could stent actually this gallbladder, and instead of doing a surgery for this patient, you can actually do what the radiologist, interventional radiologists do, or recently even EUS guided also you can do this through the stomach. So I conclude with endoscopic papillary large balloon dilatation after sphincterotomy. It's important, so don't forget it. Cholangioscopy directed electrohydrochemical laser erythrotripsy, Annapolis fragmentation of refractory stone with a very good efficacy with a minimal complication rate. Emergence of the DS single operated cholangioscope system has expanded availability of lithotripsy. Under direct visual guidance might expand the pool of the indication. Management decision, I think that's a very important thing, should be guided by local expertise in close collaboration with surgeon and interventional radiologist. And thank you very much. And we have to thank my unit.